background, and you will see some interesting patterns in today's speaker, in this session's speaker. Dr. Thommes holds his Bachelor of Science in Physics from University of Alberta, a PhD in astrophysics from Queen's University, and subsequently postdoc experience at UC Berkeley, NASA Ames, and University of Toronto and Northwestern Universities. He then advanced his career in pharmaceutical companies, first in GSK, and then before move on to Takeda, Canada, and then he is now a member of the Modeling, Epidemiology, and Data Science Group in Sanofi Pasteur Global. And very proudly, he is also a joint professor in the Department of Mathematics and Statistics at both University of Guelph and York University. So Dr. Thommes, please.
Thank you very much, John Hong, for the kind introduction, and thank you to the organizers for the opportunity to speak. A big part of what we do in the modeling, epidemiology, and data science, or MEDS team at Sanofi Pasteur, is to conduct studies, conduct research with external partners, academic partners generally. And I think I'd probably be able to speak on behalf of the rest of my team to say that, this is pretty much the favorite part of our job. So what I want to do is to give an overview of some of the things that we're doing with partners, with external partners at the moment that are related to modeling and to COVID-19. And I have to apologize a little bit for maybe stretching the definition of the theme of this session, because looking through all of these, I realized that these are all really more on the side of non-pharmaceutical rather than pharmaceutical interventions. But in any case, just quickly by way of disclosure, of course, I'm an employee of Sanofi Pasteur, and some of this research has been, or was, or will, or is continuing to be financially supported by the company. So I have sort of a big number of diverse things to get through, and I'm probably not going to do any of them the amount of justice that they deserve, but we're spanning the range from COVID testing to agent-based models of transmission in mass gathering settings. Another thing, it's a little bit peripheral, but I wanted to put it in anyway, using Ontario hospital admissions data. And then some very interesting things that we're just starting on, which involve using machine learning for early identification of emerging variants of concern, and also of using mobility data to better understand and potentially forecast the evolution of COVID. So the first thing I want to talk about, and really I wanted to put this first because it was chronologically the first. This is the first post onset of COVID thing that I worked on with a research group that I'm part of at University of Guelph, and also with MEDS. Which asked the question, in the absence of any vaccines or other therapies, what could you use in your toolbox that would get you out of what at the time was, the prohibitive and all-encompassing lockdown and distancing. And the idea here is, how far would you have to push the idea of testing to get us out of this? What, if you use this was the only thing potentially in our toolbox aside from actual, locking ourselves in our homes. And of course, the idea is simplicity itself. If you can reduce the amount of time that a person is able to transmit the disease, then you reduce the effective reproduction number. And so we wanted to mathematically model in a simple way was how rapidly really would you have to take people out of circulation via identifying them with testing? So not testing them because they're displaying symptoms, but just testing them as a matter of course, and doing so repeatedly. And basically the results, it amounted to requiring that you would have to test an entire population at a rate of in the neighborhood of once every 5 days, which of course seems dauntingly, like a dauntingly big undertaking, to put it mildly, and probably not something that one could in practice put into place. But, you can imagine putting in, sort of compromise versions of this, the idea being that you would have a trade-off between how much you would reduce transmission through rapid testing and continuous testing and isolation, and how much you could then scale back other measures. And so now we have to be real careful, though, because this figure of we test once every 5 days, everybody gets tested once every 5 days, we're okay, we can pretend like there is no COVID. This is definitely not, do not try this at home for Omicron. This is with reference to the original variant. So of course, as the reproduction number has gotten higher with subsequent variants, these results will be accordingly modified. Another really interesting project that we're working on right now, this actually came out of previous work that we were doing with York University on studying potential meningococcal disease transmission at Hajj, at the Hajj pilgrimage in Mecca every year. And then this got spun off into COVID. So this is a collaboration now both with York University and with a research group at MIT led by Lydia Buruiba, who specializes in hydrodynamic simulations and lately, especially hydrodynamic simulations of disease transmission, of droplet transmission. And the idea is, so we have here a before and after picture of what Hajj looked like before COVID and in its socially distanced version during COVID. So, significant difference there. The one is a mass gathering event. The other one, you can argue maybe is not, or is a very low density one. Now, the idea is if, you can do very complex and very high fidelity hydrodynamic simulations, as the group at MIT does, of what happens when an infected person exhales a plume of, droplets and air. How does that interact with the surrounding medium? How does it interact with other people? What difference does it make how fast the person is walking? And so they've done quite a few of, very extensive simulations on this. And you can actually see here, this is not a bad approximation of what Hajj looks like now, where you have these concentric rings of people that are walking around, in this case, sort of simplified people, but you can see that they're leaving these wakes, turbulent wakes behind them as they go. But if one wants to get to, a more, a more populous version of this, something that does actually get back to the realm of mass gatherings, of course, hydrodynamic simulation really isn't computationally tractable anymore for doing something like that. So the idea here is, can you use the results in a simplified sort of way from hydrodynamic simulations, put them in an agent-based model where each, you're not modeling every individual plume coming from every person, but rather you're using kind of an average version of what you get from the hydrodynamics. And so this is currently underway. Another project, and again, this is the one that I sort of only tangentially bears on COVID, but I thought it was an interesting example to mention anyway. We're collaborating or starting to collaborate with here in Ontario with Kingston, Frontenac Lennox, and Addington Public Health, who you may have seen operate this really nice respiratory disease mapper, which is fed by actual real-time hospital admissions data coming. This is called the Acute Care Enhanced Surveillance System, or ACES. which gets in admissions data in real time, then uses natural language processing to classify things by syndrome. And so what we are starting to work on is, and this is for the moment centered on RSV and flu actually, but we are working with them to feed this information in real time into a forecasting model. And one of the connections here with COVID is this is actually being built from the already publicly available York University COVID forecasting model. And there's a snapshot, a screenshot of it there, and the web address that you might want to go look at. And so the idea is to adapt this to flu and to RSV, but also potentially we may do this for COVID altogether. Another project that we have started to work on is using machine learning to try and do early identification of emerging variants of concern. And this is actually also involving physicists. So these are a group of nuclear physicists from Lyon. And they've been using machine learning and cluster analysis on sequencing data by looking at spike proteins and classifying classifying things by cluster, and at the same time by incidents to try and identify emerging and persistent new variants as they emerge. And so this data is drawn from GISAID. So far, they've been focusing primarily on England as kind of a test and validation exercise. And they've demonstrated the ability to actually identify, or at least flag variants quite early on. So in this particular case, now this is working backwards, or asking when would one have flagged it. But they identified the alpha variant here quite a few weeks before it was classified as a variant of concern by the WHO. And so we're working on this right now with them. And in particular, there's a postdoc at University of Guelph who is working with them to run these sorts of analyses for Canada using the Canadian GISAID data. Another interesting area, and this actually spans a couple of different things that we're working on, like I said, is using mobility data for modeling and for forecasting. And this is a collaboration partially with the same group. So they do a lot of different things. And also with Mihai Nica and Monica Cojocaru and one of our postdocs at University of Guelph. Of course, the underlying idea here is we know that human mobility is central to how disease transmission works. People transmit, people carry disease from one place to another. And when they're in a given location, the disease transmission depends, of course, on contact rate amongst people and on the transmission, the transmissibility per contact. And so the same group in Lyon, of physicists, were working also on this. And I should say this entire page is stuff that they have done already, and that they've published quite a few things. And I'm just showing this sort of as the jumping off point for what we are working on with them now. So the idea is that they use a renormalization group approach from physics, which is something that nuclear physicists make use of when they're dealing with things that vary across large scales, in this case, scales of energy. And they adapted this to epidemiology, and combining this with open source air travel data for the US, they actually managed to reproduce quite well the geospatial timing of the first couple of waves of COVID across the US. And so very interesting work. And, then we started talking to them, and then we combined this with another thing that we had within meds that we had been, another connection that we had made, or a data vendor that we'd started talking to. Specifically, this is a company called ebiq in the US, which would, I guess, call themselves a location intelligence provider, meaning that they source data from people who have opted into sharing their mobility data through, some set of apps that are ebiq related. And so these, all of these users then are essentially acting as tracers within the population, which give you an idea of how people are moving place to place at the county level in this case. And also you can get an idea of how of local contact rate. So the other element of what we're talking about. Now, it's not the contact rate exactly, it's more of a proxy for the contact rate. But a lot of us now are familiar with the Google mobility data, of course, which is fantastic, but which has some limitations. And one of the things is that if you want to turn it into contact rate, you have to go through a number of steps and a number of assumptions. The ebiq data gets you there, one would argue, more directly. So we are now working with Corentin and Giacomo on taking their previous work and combining it with now not just airline data, but also this more highly granular data from ebiq, to get a more high resolution view and to retrospectively understand and to potentially in the future forecast the geospatial dynamics of COVID. And the idea is to first look as they were doing originally, especially at the very early stages of the disease. And so what we realized is that in order to do this, we needed to, as a first step to get it sort of a notion of, okay, we have all this data at the county level. We need to have some sort of a notion to make this tractable of what are, connected regions, what are strongly connected regions, what, clusters of counties can we stick together and say that these act more or less as one region. It's kind of analogous to, if you know of these CSAs, combined census areas in the US, they sort of attempt to do that. What we're trying to do here is to do this, computationally in a data-driven way, and possibly in a time-varying way, because as you can imagine, especially early on when the lockdowns first started happening, this sort of clustering is probably going to change radically, over a matter of weeks or even days. And so the idea is that this will give us a strong starting point for then looking at a more sort of high resolution geospatial disease evolution, and also being able to use this maybe as a laboratory that will inform and help us with future pandemic preparedness, which is something that we're also very interested in. Also, and I'm just going to touch on this very briefly, the other side, of course, that you can use this data for, like I said, somewhat more directly than Google data, is to infer contact rate. And now, of course, we know mechanistically we can essentially in time series analysis language, we have a transfer function that takes us from mobility to contact rate to disease transmission. And so if we know the mobility and we know what the epidemiology has to come out at the other end from surveillance, we can go in and infer the transmission probability per contact. And so we can do things like, this is extremely preliminary work, but the idea is, we can get some idea of, early on, you can see here, this is for the state of Georgia, Early on, the per contact transmission probability was fairly high. This is before anybody had even really reacted, before we knew that wearing masks was a good idea. And basically, this doesn't start to significantly increase until people start to significantly practice NPIs aside from distancing, because the idea is that using mobility data, you've already encompassed the actual, you're already depicting the distancing itself. What you're now looking at is reduction in transmission probability per contact on top of that. And so this, as you may guess, also has the potential to be used for forecasting. I'm just going to end with a quick plug here for something related to all of this, and something that is intended to serve as kind of an umbrella for exactly this sort of work. Sanofi, Pasteur, and MEDS in particular are part of a collaboration, or part of a group which includes also the University of Lyon and the Lyon Hospital Network, that are in the process of setting up something that is going to be called the Center of Excellence for Respiratory Pathogens, or CERP, in Lyon. And the idea is to have this be, well, pretty much what it sounds like, have this be a hub that facilitates this sort of research, that brings together researchers from, not just France, not just Europe, but from around the world, and very sort of analogous to the kinds of things with York University and the Industrial Research Chair. And so, anyway, stay tuned. Hopefully, there will be more to come on this, and opportunities to hopefully interact, and some, I guess, closing thoughts. And these are fairly generic, and I think that if anything, they relate maybe more to the session earlier today than this talk even. But I mean, I was looking at this and trying to think, this does not necessarily relate directly to the question of endemicity. How can we draw the connection there? But I think the theme that we're seeing everywhere, certainly, maybe even more so earlier this afternoon, is I mean, COVID started out actually very simple. I mean, simplicity itself. You have a 100% susceptible population, which is the whole planet. You have a disease whose reproduction number you can figure out fairly early on, just from looking at the exponential growth, and the reproduction numbers may be in the neighborhood of 2 to 3. You can look at that and you can calculate, what's the epidemic final size for a reproduction number of 2. It comes out to be 80%. So if nobody did anything, 80% of the world gets infected, catastrophic loss of life, and so on and so forth. Of course, fortunately, things got much more complex very quickly as behaviors started to come in. There were lockdowns. We started to wear masks. Policies came from governments and public health with varying degrees of compliance. People would look exactly the sort of thing that we were hearing about this morning, this complex feedback between looking at the epidemiology, reacting to it, changing your behavior, then the epidemiology changes. Now, it's hard to think of finding even a semi-stable equilibrium in such a complex system. And so if the question comes to, the question of, endemicity, I mean, if we want this to be truly analogous to seasonal flu, we would have to reduce it to more or less the same number of moving parts, which is just, on the one hand, the evolution of the disease itself, so emergence of new variants of concern, how effective the vaccine is at a given time. And of course, the behavioral part still is there in the form of what's the vaccine uptake, how many people are currently vaccinated or are vaccinated this season. And all these other behavioral things, if we're still in a state where we're trying to encourage people to wear masks, we're increasing or decreasing lockdown measures, it's still a complicated system. And I would argue that even if we find ourselves in something that looks like an endemic state, it's probably a fake endemic state, which will collapse as soon as we start scaling back some of these measures. So perhaps, the way to look at it is it's not really an endemic state until we're no longer having to practice NPIs. and it really does look like flu. So anyway, that's I guess all I would have to say about this. And finally, just again, a big thank you to all of our collaborators in this work. And it's really exciting to have the opportunity to work with so many smart people. And thank you very much.